This podcast series is made possible thanks to the generous support of the Patient Care Foundation. The Patient Care Foundation supports medical students in need through scholarships. Each year, the Patient Care Foundation changes lives forever by giving deserving medical students facing incredible odds funds to continue their education, resources as they deal with food, housing, and transportation insecurities, or other challenges in the wake of COVID-19. Thanks to Dr. Troy Elander, Chairman of the Patient Care Foundation Board, and Elizabeth Kurihara, Board Member. Welcome to this edition of Clear as Mud, the podcast dedicated to bringing clarity to medicine. I'm your host for this episode, Gustavo Friedrichsen. You had a vision to start a company based on what you were seeing, what you were experiencing, personally and professionally. What inspired the vision to create Aledade? And what is the vision of Aledade as a follow-up to that, if you wouldn't mind?
Yeah, I had spent my career trying to connect public health and healthcare and asking the question, how do we save the most lives with medicine? And it seemed like a question that we have so much opportunity, so much potential through prevention, through primary care to save lives. And we just weren't doing it. We weren't funding primary care in the right way. We weren't doing prevention the right way. And I kept, banging my head against the wall for 20 years, Gustavo, saying, oh, okay, maybe this is a technology problem. Maybe it's a workflow problem. And then finally I realized it's a money problem. It's that this gosh darn system is fed by people having strokes and having heart attacks and having kidney failure. And then the system will spend literally anything on that person at that point, but no one wants to spend money preventing those things from happening. And so this idea came out with accountable care, that if primary care docs could get together and have the right data, have the right contracts, have the right tools, but show what they're capable of reducing hospitalizations, which we know we can do with better prevention in primary care, then they get a piece of it. Like, I didn't have the idea. The idea had me, if you know what I mean. Like, it had me by the neck and wouldn't let go. And it said, someone's got to do this. Someone has to create an easy button for independent primary care doctors to be able to take total cost of care accountability, which means if you prevent a hospitalization, you get some of that benefit, which right now docs don't get.
We're talking to Dr. Farzad Mostashari, founder and CEO of Aledade. Did I pronounce your last name correctly, Farzad?
Perfect. Okay. Sorry to just launch, man. I'm so passionate about this.
I love it. This is really exciting. The value to primary care, and Dr. You and I have been working a lot in the FQHC space, obviously. Help our members, help our listeners understand what the value is to primary care doctors, and then transition to FQs as well, if you wouldn't mind.
Yeah. One of the key kind of insights that we had early on, I remember just scribbling on napkins and blackboards and whatever, anyone I could talk to. I was like, do you realize, we published this in JAMA with Mark McClellan back in 2013, do you realize if you take 100 primary care docs and you take their patients, their panel of patients, that's $1 billion in annual healthcare spending, right? So that's the key thing is primary care has the opportunity. It's Archimedes' lever to move the world. And if primary care has the right kind of contracts, the right kind of tools, and the right playbook, they can move mountains. Federally qualified health centers are really, really interesting because they've been doing community health since before it was cool. And like you talk about interdisciplinary team management, having pharmacists and care managers and social workers involved. You talk about social determinants of health. You're talking about like taking a holistic view. Like, they have all the pieces, but they too have never put it all together and say, what if we could actually put all this to work and prevent hospitalizations and get a piece of those savings from the single biggest source of suffering in the healthcare system, and not be worried every single time, like, are we going to get that grant continuation? Are we going to get that PPS rate reduction that we've all been afraid of? Like, that is when we turn things on its head. And the strongest people in fee-for-service are the hospitals and the health systems. Why? Because they're big. Just that. Just the bigger you are in fee-for-service, the more leverage you have and the higher rates you get paid. But in value-based care, what matters isn't how big you are, it's how good you are. And I'll tell you, FQHCs and independent primary care practices are good. They're good for patients. They're good for society. They deliver high quality care. They give people choice. They're responsive to people, and they deliver care at a lower price, better care at a lower price. And that's what should get rewarded, and finally is being rewarded.
Yeah, that's music to their ears. And if they're not listening, they need to listen to the music. And that's what we're trying to do, right? Is connect your
Opportunity.
organization to that model. And we're getting there. Slowly but surely, we're getting there with that particular part of the industry. I love how you use the cancer word, but I love how you described misaligned incentives, right?
Yeah.
And I couldn't agree more that there are so many misalignments within the industry. I call it the ultimate fragmented society, right? But you call the misaligned incentives from a PCP, FQHC, and group perspective. What are those misaligned and how can you align them better? Or what does Aledade do to align them better?
Yeah, I mean, fee for service, right? Like what's the incentive? Fundamentally, the incentive is to wait until someone gets sick. And then the more you can do to them, the more you get paid, right? And in particular, what you don't get paid for is like talking to people and doing cognitive work, right? What you get paid for is cutting people and sticking stuff into people. And so that doesn't make any sense. That's the system isn't aligned with what's best for the patient. What's best for the patient is for them to be kept healthy and out of the hospital. What's best for society is to lower healthcare costs. But what's best for healthcare is for people to get sick. Everyone goes to medical school to do the right thing. I'm not talking about individual doctors and nurses or even administrators. I'm talking about the system. The system is keyed to wait until people get sick and then charge a lot for them. And now let's talk about primary care. What is the measure of productivity? What's the measure of productivity that someone might use for a primary care provider who becomes employed by a health system, right? RVUs. If an RVU is your measure of productivity, then what's the product? What's the product of primary care? Visits? Can we squeeze more and more visits into shorter and shorter time? I mean, this is the thing that amazes me is what doctors want and what patients want is the same thing. They want to be able to have deeper, longer conversations with each other and really deepen that relationship. And like the current system, the incentives in the system are, can you get them out in 12 minutes? Can you get them out in 10 minutes? Can you get them out in 8 minutes? 5 minutes is even better, right? Like that's no way to do primary care, right? Someone comes in with 3 problems and be like, go out and come back in 3 weeks if you can't, or immediately, reflexively, like go see this specialist and that specialist. That's not what people trained in family medicine and primary care to do. So the incentives are misaligned with what patients want, what patients need, what's good for society, what doctors want. Whereas with value-based care, outcome-based care, whatever you want to call it, the incentives become more aligned, where what's good for the patient, stay out of the hospital and healthy, is what's good for the doctor too, in a major way, like in a big way. Like you can make urologist money doing primary care. Isn't that great?
On such a basic level, spending more time with a patient is no different than spending more time with a spouse or a partner or a family member. And when they feel like you're giving them your time, I can't imagine the clinical outcomes with that, blood pressure and just, lifespan and quality of life and feeling valued.
Yeah.
I mean, in the current health system, patients feel devalued, which leads to stress, anxiety, and all these other things, right? So then you get the missed handoffs and the phone calls that aren't returned and being lost.
And also, I mean, you talked about patients. How about providers? How about physicians? I mean, when people talk about burnout, I think it's moral injury. And I think that moral injury is from when you know that the duty you owe the patient can't be supported by the duty you owe your employer. Your employer says, get him out. And you know in your heart of hearts that like this person needs a little more time with me right now. Not every patient, not on every visit, but like very often you'd be like, you know what? I should stay here and talk to the patient about their wife's dementia, what their choices are, what their preferences are, how to help them be better with the medication adherence or quitting smoking or taking a vaccine, right? Those are conversations that can help the patient. And you're sitting there feeling like, I can't do it, or send the referrals in. Like you're not supposed to send them to that independent high value specialist. You're supposed to send them like, how come we're not getting the patient in for the specialist or the surgery center or the MRI, right? Like you're not feeding the beast here. So I think that's a lot of what moral injury is when you're being ripped apart.
My gosh, I have like 15 questions, but every time you answer, I feel like asking 10 questions within the answer. So just forgive me for this, but I want to make the most of your time as well. You're working with about 1,000 PCP practices every day. What has that been like? And what are you gleaming from that? What are you sort of deriving from that, those 1,000 PCPs that you're working with every day?
Yeah. I mean, it's 10,000 clinicians in 1,000 different practices. And it's everything from literally solo practices in California to federally qualified health centers in Mississippi Delta to IPAs in Philadelphia to, rural health clinics in Kansas, right? It's just the entire range of primary care in America. And I mean, one of the things that is reinforced every day for us is service, that we know who we work for and we know who the heroes are. And it ain't us. The heroes are the frontline primary care physicians and practices in America. And they need our help. And we have a duty to care for those who care. That to me is the common thread is everyone's experiencing some variation on the same thing. COVID was a trauma. And things have not been going well for a long time. And it often feels like there's no, what's the way out, right? And what's exciting is when we can say, we will help, you can join a collective, right? That there is strength in numbers here, but stay independent. And we will never ask you to do what you don't think in your heart of hearts is what's best for patients. And this will be the future, but you won't be alone. So that to me is the commonality of serving 1,000 very different practices in very different parts of the country, but they're all unified in their mission to serve patients, and we're unified in our mission to serve them.
I mean, so we have literally hundreds of PCPs that are members of our organization, my organization, and I'm sure they're going to ask the question, or they think in their minds, I don't have the infrastructure to partner with Aledade, and that's a huge misnomer, right? So what type of infrastructure does a typical PCP practice need to have? And back to the FQHC model, because we've got 6 now that are members of my organization. What type of infrastructure does a PCP need and an FQHC need to be a partner of Aledade?
Not much, right? Like we'll bring the contracts, we'll bring the data, we'll bring the software, we'll bring the playbook, we'll bring the coaching. What you need to bring is your heart, right? And your engagement with this. The one thing that we do say is like, you can't be on paper and pen in this day and age. And if you're still on paper and pen, then maybe we can help you get on electronic health record. But that's the one thing that you got to be digital to participate. Other than that, we work with 100 different electronic health records. Doesn't matter what you're on. We'll bring what you need. We don't charge you for like software or consulting or fees. We get paid when we create savings and when you get paid. So our incentives are aligned as well.
Yeah, that's usually the second question the doctor asks, right?
Right. How much is it going to cost? How much is all this going to cost me? It's actually, it's free. We'll pay you.
Explain why you don't consider even buying. I mean, that's the other thing too, right? Is that many physicians might think, wait, Aledade is going to buy my practice or they're going to acquire my practice. I can sense now that your model is
not our
really
game.
about partnership, right? So explain that a little bit more.
Yeah, I mean, look, there's a lot of people want to sell their practice. There's been lots of buyers who would be, whether it's the hospital or Optum or whatever, who private equity who'd buy a practice. But I want people who take pride of ownership and who have built with their hands a trusted relationship with their patients. And I want to serve them. I want to work for them. I don't want them to work for me. They know how to do primary care and we're going to help them. But I think there's this kind of management capitalism concept that like the way you get doctors to do what's the right thing is you have to employ them and tell them what to do. And it's like, that's fundamentally BS, right? Like doctors know what to do. You just have to let them do the right thing. It's not like you need to employ people so that you have some 25-year-old with a stopwatch standing over their head.
Yeah, when I talk to PCPs, they're just so, imagine there's moral injury, there's the patient volume, there's losing staff, missing staff, COVID 2.0, COVID 3.0, whatever you want to call it. There's all these things that they're dealing with. When I was watching the other day, you mentioned the term precision population health.
Yeah.
And I want to get into that a little bit more because we're in the business of educating our members, right?
Yeah.
Exposing them to new ideas, exposing them to new solutions that they may have not even thought of. Like I can literally visualize a PCP in front of me right now saying, population health is not even in my lane. I can't even talk about that right now. Well, wait a minute. There's something that you really talk quite a bit about, which is precision population health that they could be a part of. Can you explain that a little bit more?
Yeah. So I've done quality improvement work for 20 years. And 20 years ago, I would have said, if you want to grab a new habit, you got to do it for everybody, right? And that's a lot of people still think that that's the world we live in, right? Where you just have to do the same thing for everybody. Everybody who's, this gets that. And the reason why we had those rules was because we didn't have the technology, right? We didn't have technology assisted workflows where, you had to like literally do the same thing for everybody. But I think that wastes a lot of effort. So if I ask you the question, look, 1% of your panel, of your flock is in the office today. Okay. Of the other 99%, who needs a call? Are you going to call everybody every day? No, of course not. But there's probably another 1% who are the people most in need. They're the people who are languishing in the skilled nursing facility with no discharge plan. They're the people who just had an ER visit and are at high risk for bouncing back to the ER. They're the people who have the highest opportunity for primary care making a difference. They haven't seen you, right? So being able to create prioritization for practices and not have it be impossible to deploy, right? Because the technology, like someone in the office is going to turn on the computer every day and there's going to be a work list and it's going to say, if you're going to call 10 people today, these are the 10 people to call. That's precision public health. It's where do we get the biggest bang for the buck? Where do we get for the effort? And time is limited. We can't do everything for everybody, right? But where are you going to get the biggest benefit from? And let's do those things first.
Yeah, and I want to get into the technology first, okay, because that's usually the third or fourth question the doctors ask is it's too cumbersome, it's too complicated, it's not user friendly. What are we talking about? Is it a dashboard? Is it an app? What is it exactly? So can you explain to today's PCP and also to today's Chief Medical Officer at an FQHC, can you explain the technology and how easy it is to use, if you don't mind?
Yeah. So it's, we are best in class, right? Like KLAS, the big healthcare IT consulting group that gives best in class awards. They've awarded it for 2 years and we've won it 2 years, right? Best in class software. But what does it mean for population health? I think it is to not just create a dashboard, but to bring all the data from outside your practice that you don't necessarily know about and bring it in with not just data, but insights, and to create actual workflows for different people in the practice. We have a really high usage rate, right? 90% of our practices are in the tool every day. That's not like a, payer portal, right? Like how often are physicians looking at the payer portal? Right? Never. You forget your password every single time. You have to forgot password, right? Because you're never in there. 90% of our practices are in the tool every day because it actually helps them. So what does it do? So there's different workflows for the different people in the practice. The workflow for the clinicians, let's start there. It's to prevent those times when you get ticked off because you should have known something and you didn't know it. So how often have you had the experience where you're talking to the patient and maybe you're like, you got your hand, like you're halfway out the door and the patient mentions like, oh yeah, and by the way, my cardiologist, and you're like, wait, what? You have a cardiologist? Right? Or, you went to see this other primary care doc, right? Or when you're trying to figure out why their blood pressure isn't well controlled and whether you should add a third blood pressure agent, and then you happen to find out from the wife, he's not taking the medicines, right? You should know that. If they're not filling the prescription, you should know that. Do you know that? Is the pharmacy calling you to tell you? No. Is the health plan calling you to say, here are the specialists they've seen? Is anyone telling you like, oh, they got their mammogram or the DEXA scan over there across town? No. Is someone telling you that they tested positive for COVID? No. Is someone telling you that they went to the ER? No. But here we bring all that information into literally a piece of paper, like 8.5 by 11 sheet of paper. We have a great video that one of our FQHC leaders, you can see her flipping through her patient's Aledade one-pager and seeing the medication adherence issues, the misdiagnoses or the care gaps issues all in one place. So bringing all that to the point of care, all that information from the outside world, right? From outside labs that you aren't piping into your EHR, from outside health plan information, pharmacy information, real-time event notifications. So we set up all of those data interfaces. That's one. Two, it's a workflow for not the physician, but there's a nurse function, right? Where someone who's just been to the ER, when you open up the app, the homepage says you had 4 people who visited the ER yesterday or in the past couple of days, like click here to call them. You got, 3 people who just got discharged from the hospital. And oh, by the way, If you call them twice within 48 hours and then you see them within 7 to 14 days, that's like a $250 office visit. And like 7 of those prevents a readmission, right? So it's good for the patient, obviously good for society, and it's good for the practice. And we know that practices aren't maximizing those really high value fee-for-service opportunities. We're not getting any cut of that, right? But we're helping the practices be able to have create higher value primary care, advanced primary care services. So more transitional care management, more annual wellness visits, stuff like that. And then giving access to things that maybe the practice doesn't normally have access to. So you have a complicated patients with disabilities who's, if you ask them the doc, the surprise question, would you be surprised if the person dies the next year? They'd say like, no, I wouldn't be surprised, right? But you don't have the time to spend an hour talking to the patient about end of life wishes and bringing in the daughter from California and the son from New York and right, documenting all this stuff. Well, we have a service free for the patient and for the practice where we will do those hours-long conversations and documentation. So it's those kind of things. Then it all comes together and care management functions, obviously, for a lot of the FQHCs that tracks, who to enroll, who's, time, work, task management, who's in the office today. So one software that has work lists, it has referral opportunities for high-risk patients, it's got care management, it's got a huddle view, and it gives you a sense of how you're doing in terms of your patient population. So all in one, cloud-based, tied into your EHR, to the local health information exchange, and it's free.
Well, that's exciting. And we've got a great partnership with Lanes, right, which is the local HIE.
That's right.
I know we're pressed up against the clock. I just want to ask one last question because it's pretty exciting, I think. What is Aledade Health Solutions? I know you announced that some time ago, and I made a note of it right away. I got to ask Farzad about Aledade Health Solutions, and just like a Reader's Digest version, what is it and how does it benefit PCPs or the industry?
Yeah, I was talking to the other this payer who said they have 61 different point solutions, and I'm like, how do you integrate those into primary care? And they're like, yeah, we don't know. We'll just call the patient out of the blue and we'll say, do you want this? We have this diabetes thing. You want this? And they're like, and it doesn't make any sense. Right. So what we realized is that what we need to do is we need to integrate these third parties. Some of these third party solutions are quite valuable, like the end of life healthcare planning service that I described, but they really should be integrated into primary care. It's beyond the capability of what the average primary care practice can do, but you don't want it to come out of the blue from the health plan or someone to your patient and you not be in the loop. So this is a way to give control of that to primary care, to have wraparound services that actually wrap around primary care and are can be, again, precision public health, right? Like micro-targeted to the patients who would benefit the most. So, we have all the machine learning and AI algorithms to say like this patient would be most impactable for this service. And we're going to give that recommendation to the practice at the point of care and connect in with the patient. And we see higher engagement rates, we see more appropriate targeting, and we see the benefits of reduced hospitalizations or costs being, benefiting not just the patient, but also the practice.
Well, Farzad, I know we're at 35 minutes after the hour, and I can't thank you enough. I mean, I know that you're extremely busy, and I really say this from the heart, that I appreciate the time with you. Every minute with you, I'm learning something new, and I appreciate you for what you've built and what you're doing. And we love the partnership with Aledade because we're also trying to improve medicine. We're also trying to improve, the patient experience and outcomes. And we're also trying to be a disruptor in our own little way here at the LA County Medical Association. And Aledade, I think, is joined with us hand in glove to be disruptive force in the LA market. So
let's build it together.
Let's build it together. Appreciate you. The next time we meet, I'll have a bow tie on. I promise you. And thanks again for being our guest on Clear as Mud, and appreciate you, and have a great day, Farzad. Thank you again.
Thank you.
Many thanks to our sponsor, the Patient Care Foundation, for their generosity, and our production team of Gabe Zuniga and Dennis Chung. Thank you to Noemi Corona and our LACMA team for coordinating today's podcast. I really want to encourage our members to go to our website, ladocs.org, and visit the preferred partner section, the benefits section, and really just navigate the opportunities and the resources we have for you there. Check out the Monday RX and the Tuesday RX to learn about the offerings, and of course, download the Clear as Mud podcast and share this with your colleagues. So tune in next time to Clear as Mud. With that, I'll say thank you and thanks for listening to Clear as Mud. Be safe and have a joyous and healthy week. Thank you again.